For this session this afternoon with Maida, we'll be looking at a lot of details on the traumatic pelvic hemorrhage. And the way I do it is through an evidence-based decision making. And the evidence-based that I'm going to review with you are current. And the main references will be, number one, will be the Eastern Association for the Study of Trauma, the guideline that was published in 2011. But there is a more recent one that is published last year by the World Society for Emergency Surgery. So we'll be looking at them and comparing them. So the thing that you have to understand, especially if you are in the emergency room, is that the risk of mortality increases by 1% every 3 minutes that the patient remains hemodynamically stable. Especially with pediatrics, sometimes they are deceiving. They are playing. We had one case before. It was a malpractice case. I still remember it. The blood pressure was seemingly normal. Heart rate was seemingly normal, playing in the emergency room, so they think they can buy time. But what was missed in the CT scan, there was no active bleeding in the CT scan, but they missed the classic picture of hypoperfusion syndrome, because they can present with hypoperfusion syndrome even with a deceivingly normal, seemingly normal blood pressure and heart rate. So you have to take into consideration not only the physiologic parameters, the mechanical parameters, and also the imaging parameters. So the bleeding sources could be from the bone, could be from the artery, it could be from the vein. And the anatomy of the retroperitoneum is that it provides tamponade because it is a tight space. But once you break the pelvic ring, that tamponade is lost, and therefore these are prone to bleed. And according to this data, you would see that as you separate the pelvic ring, if you look at the pubic symphysis, and you go to a distance of 3 cm, you will increase the volume by twice, from 4 liters to 8 liters. And therefore, the tamponade effect is lost, and the patient is prone to go into fatal exsanguination. And the other contributing factor is the lack of valves in the IVC and the iliac vein. So they don't prevent the blood loss because it's normal for them that they lack valves in the IVC as well as in the iliac vein. So therefore, there is a role for pelvic fixation initially. It will temporarily bring back the tamponade into the open or disrupted pelvic ring. And the source of bleeding is 80 to 90%. That is the strongest argument, wherein the initial management should be a pelvic binder, external fixation, because most of the time the source of bleeding is from the vein, 80 to 90%. But you don't know when you will have arterial bleed. There's no way of knowing it clinically unless you do imaging. And therefore there is a debate whether to proceed with angio or initial pelvic fixation. But of course, you have to make use of imaging for you to know that the bleeding is coming from the vein or the bleeding is coming from the arterial blood vessels in the pelvic system. If the bleeding is arterial, then you have to go to embolization. And you have to know that even if a patient presents with hypotension, poor response to resuscitative efforts like fluid administration will give you a possibility of arterial bleeding in about 70%. So run response to transfusion or resuscitation will give you a bleeding incidence of 70%. And responsive patients are likely to have arterial bleeding with a negative predictive value of 100%. Meaning, if the patient is not responding to arterial bleeding or responding to arterial bleeding, but if they respond, then the presence of response will give you a negative predictive value of 100%. But one particular study that I will be reviewing with you has some modifiers. And it's a very good study. I will review it with you, and they were able to identify 2 subsets. One subset initially presenting with hypotension in the ED, and the other subset presenting with no hypotension in the ED, and these two subsets would behave differently with regards to how they proceed after initial encounter in the emergency room. So question number one, are there any radiological findings that predict hemorrhage? So you are presented with the trauma, the three views for the trauma, the pelvic AP view, the chest x-ray, and the lateral spine, and you see this. Is there any way you can predict bleeding? No, you cannot predict bleeding, just from the plain film. And it has been studied that the fracture pattern of pelvic x-ray does not single-handedly predict mortality or the need for angio. And the presence or location of the hematoma neither would predict or exclude the need for arteriogram, and CT of the pelvis is an excellent screening tool to exclude pelvic hemorrhage. The absence of extrab does not always exclude active hemorrhage. Why? Hunter? No, the new Hunter. Because remember, decision making is our brain is wired. Look for extra. Okay, we will address that later on as we look at the evidence base. And pelvic hematoma of more than 500 cubic feet in size has an increased incidence of arterial injury and the need for angio. How do you quantify hemoperitoneum? Or you just say hemoperitoneum. You have to quantify because it has been found that a hemoperitoneum more than 500 ml will increase the incidence of arterial injury and the need for arteriogram. How do you do it? We'll go to that. And you have to remember, what?
Are you waiting on anybody to answer or just the normal?
You want to answer?
I mean, you measure the four quadrants, just like when you have you have any one quadrant over 8 cm or multiple quadrants over 4 or 5. And how you say massive hemoperitoneum.
Are you familiar with the approach of Federally? It is a publication in 1985. Okay, we'll look at that. And then when looking at pelvic fracture, don't disregard isolated acetabular fracture because they can cause bleeding in the same way that other fractures can cause bleeding. And then this is a clinical prediction rule. It will give you an inkling on what is the likelihood of having bleeding when you have these parameters. And they were able to look at parameters: unstable obturator ring fracture, displaced pubic symphysis, displaced sacral fracture, and the SI joint displacement. And then finally, they were able to come up with these 4 parameters: displacement of obturator ring fracture equal to or more than 1 cm, displaced pubic symphysis of equal to or more than 1 cm, and 2 physiologic parameters: hematocrit of equal to or less than 30%, and a pulse rate of equal to or more than 130 beats per minute. You would see that the odds ratio attributed to a low hematocrit will be about 6.6%. A displacement of the obturator ring, mechanically unstable pelvic ring fracture will be about 4%. Similarly, with the pubic symphysis, about 4%. And a pulse rate of more than 30% is 3.3%. When you look at these parameters, when you don't have any of these 4 parameters, the probability of having a major hemorrhage is only 1.6%. Then as you go up to 2, it jumps to 46%, and much more so when you go up to 3 or more, the probability of hemorrhage becomes 66%. And not only that, when you look at the presence of 3 or 4 parameters being predictive as to the presence of pelvic bleed, you would see that the specificity is 96%. So positive rules in with only a false positive of 4%. The specificity of 96%, the false positive rate is equal to 4%. Good diagnostic test. What predicts bleeding from the CT scan? So you would say this is a triphasic one. You will see the arterial phase. There is already a bleed on the left pelvic sidewall that is adjacent to the area of the comminuted fracture in the left iliac wing. You would see that this persists into the venous phase and then enlarged and then spread into the delayed phase, the classic picture of a spreading arterial bleed initially present in the arterial phase. And the checklist will be for you to look at the 6 spaces, look at the rectus seat, look at the bilateral gluteal region, look at the bilateral pelvic sidewall, and don't forget the presacral region, because there could be some bleeding also in the presacral region that was from the disrupted sacral branches. What is the clinical significance of extra? The absence of extra on the admission sheet and excellent screening to exclude the presence of active extravasation. But the negative predictive value is variable. It depends on what study you are reviewing. In this particular citations, 3 citations, the cumulative negative predictive value was about 98 to 99.8%. But other studies would say that the presence of contrast exub has shown varied results. The positive predictive value could be ranging from 69 to 80%. And sensitivity is 90%. What is the meaning of a sensitivity of 90% with regards to contrast extra? Hunter.
So if you have it, 90% of the time it's not false positive.
Remember, you need a sensitive test to pick up a fatal condition. So you need a sensitive test. So if I have a sensitivity of 90%, what does that mean? I could miss 10%. The false negative rate is 10%. A false negative. So remember, you can miss 10%. A sensitivity of 90% gives you a false negative rate of 10%. And on the other side, about 1/3 of patients without contrast extra who are hemodynamically unstable or also require arteriogram. What's the reason for that? John?
Maybe it wasn't actively bleeding at the time of the scan.
That's one. Number
Maybe
2,
it was missed, or maybe
the patient is hypotensive, hypovolemic. There's not enough driving force to cause the extract. So these are the 3 or 4 conditions that will give you a false negative rate with regards to extrav in the setting of hemodynamical instability in a patient with pelvic hemorrhage. Yeah.
Could it also be just the velocity of the flow? Like
Yes.
not being able to be picked
Yeah,
up by CTA
you don't have enough driving force. The patient is hypotensive. The patient at the same time is also hypovolemic. There was one, he's no longer here. There was one faculty in trauma. He used to pressure me. Oh, why don't you give? Why don't you challenge it? Why don't you give heparin? No, I will only give heparin or thrombolytic if you give me a triple setup. Reserve a room for me in the OR, should I fail? And the reserve anesthesiologist for me, should I fail? But challenge tests, especially if the challenge test will result to catastrophic bleeding, make sure you have a triple setup. You have an OR waiting for you, you have an anesthesiologist waiting for you, and a trauma surgeon waiting for you. And then this is a nice study, a retrospective one, although the level of evidence is low because it is retrospective, but we can glean a lot of, some insights on this. And then they were able to come up with only about 25 requiring AMBO, and they were able to do a multivariate analysis. And they found out that being old, 55 and above, hypotensive and a CT blast and contrast, this will give you a high odds ratio as to the possibility of a pelvic bleed, all of them with a p-value of less than 0.005. The other group, the presence of hematoma, pubic symphysis greater than 1 cm, open book fracture, SI joint widening, did not give you a p-value of less than 0.05, and therefore these are not significant. This is the good study that I was alluding to a while ago, a 7-year period. They studied about 1,171 patients, and they were able to come up with 2 groups, 35 presenting with hypotension, all of them had arteriogram, and the control group 17 presenting with no hypotension, also all of them having arteriogram. When you look at the first subset, those presenting with initial hypotension and then are undergoing arteriogram, you would see that the transient or no response to resuscitation is the predictor, a significant predictor for the presence of active bleeding. And take note that the presence of contrast blast in the subset of presenting initially with hypotension, there is no significant difference between the bleeders and the non-bleeders. You would see that the p-value is 0.17. The second subset is that without hypotension, an initial presentation in the ED, the behavior of this particular subset is quite different from the first subset. You would see that the presence of contrast blast is significantly different from those with bleeding and those without bleeding, with a p-value of less than 0.05. You would see that with arterial bleed, the presence of contrast blast is 60%. With no bleeding, the presence of contrast blast is only about 8%. When you look at sensitivity, you would see that inadequate or no response to resuscitation, you would see it's sensitive. Meaning, if it is absent, then it's a good indicator that you don't have active bleeding. Remember, sensitivity is snout, sensitive rules out. On the other hand, when you look at the group presenting without hypotension, when you look at contrast blast, sensitivity is low. We already explained that a while ago while the sensitivity is low. But look at the specificity. Specificity is higher, which is quite different from the first group. The specificity is 92%. So when contrast blast is present, then active bleeding is present, 92% specificity with a false positive rate of 8%. And again, the false positive rate is that by the time you do the angio, the bleeding already stopped. Can we distinguish arterial from venous bleed? Yes, if you do a multiphasic, arterial phase, portal venous phase, and the delayed phase. And then in here, side-by-side comparison with an arterial bleed, arterial phase, you see it, and then it progresses into the venous phase, and then is spread into the delayed phase. In contrast, side-by-side comparison, you will see that somebody with a pure venous bleed, you will see in the arterial phase, in the hematoma, there's no contrast blast. Then you would see that in the portal venous phase, you would see beginning enhancement around, increasing the Hounsfield units. And then later on, in the delayed phase, you would see the classic extravasation in the delayed phase. A venous bleed, arterial, and then venous phase. Arterial bleed again, similar, not arterial phase progressing into the delayed phase. And then the same patient here, also there's a concomitant venous bleed. It's not seen in the arterial phase, a presacral bleed seen only in the portal venous phase. And then this is the validation of the CT trauma, CT integration of the chest, the abdomen, and the pelvis. It could separate arterial from venous bleed if you have arterial phase, a venous phase, and a delayed phase. Is there implication of the size of the pelvic hematoma? There is. As we have alluded to a while ago, large volume hematoma more than 500 cc may have an increased risk of arterial injury requiring arteriogram. And in here, this is the validation. It's a recent study, relatively, in 2012. And they look at the need for Explore Lab and the need for pelvic embolization, and the parameters that were studied, the presence of moderate or large hemoperitoneum or absence of hemoperitoneum. You will see that the need for Explore Lab, of course, intuitively speaking, you will see that it's more in somebody with moderate or large hemoperitoneum. And likewise, the need for pelvic arteriogram is more with those presenting with moderate or large hemoperitoneum, 22%, versus those without hemoperitoneum initially in the CT scan. When you look at, again, the positive predictive value, you would see that the presence of moderate or large hemoperitoneum the positive predictive value for the presence of active hemorrhage is 39%, and large hemoperitoneum, it jumps to 62%. Semi-quantitative analysis, therefore, improve predictability of peritoneal hemorrhage. And this is the one being alluded to by Carson a while ago. This is the publication in 1983, Ct Quantification of Hemoperitoneum. So look at the location, look at the perisplenic, look at the perihepatic, look at the Morrison's pouch, look at the left paracolic gutter, look at the cul-de-sac. If only one space is occupied by the fluid, it is considered small, and the estimate is about 100 to 200 ml. If a fluid is found in 2 or more spaces, but not all, it is moderate, and it could range from 250 to 500 ml, and the volume is large, more than 500 ml, if all of the spaces are involved. You have fluid in the perisplenic, you have fluid in the perihepatic, in the Morrison's pouch, in the pericolic gutter, in the cul-de-sac, as well as anterior and superior to the urinary bladder. What is the best test to exclude intra-abdominal bleeding? And you have to be aware that in pelvic bleed, there could be an intra-abdominal source in 32%. Part of their checklist will be the spleen, about 22%, the liver in 20%, the bladder in 15%, mesentery in 10%, renal in 7%, diaphragmatic in 4%, and the remaining 22% intraperitoneal injury not associated with hemodynamic instability. So don't fall into the trap of error of sheer satisfaction. You see pelvic bleed and you forget to look at the rest. So you do your secondary survey. In the secondary survey is a complete review of all the organs, and then look at this. Look at the spleen and every organ, because the spleen is also associated with injury in 22%, in about 1/4 of cases. What is the best test to exclude intra-abdominal bleed? The FAST scan, or the focus assessment with sonogram for trauma, is not sensitive enough, but the specificity is good. Remember that the sensitivity is not high enough. Why? Diagnostic lavage is still the best test to exclude intra-abdominal bleeding in hemodynamically unstable patient. And in the hemodynamically stable patient with pelvic fracture, CT, because you can buy time, you have the luxury of time to get a CT scan of the abdomen and pelvis, then you have to do it, even regardless of the results of the FAST scan. Specificity for FAST scan is about 87 to 100%. Sensitivity is 26 to 75%. This is a good one, where if you try to look at FAST scan and what are the causes of false negative, I don't have time. You can watch it on YouTube. I don't have time, so I have to skip this one. And one of the main causes is because there are adhesions. Somebody with previous surgery, or previous inflammation in the abdomen, and therefore the fluid will not flow freely into the spaces, and therefore they will just localize in just one region. Which patients require emergent arteriogram? So we will look at pelvic instability, hemodynamic instability. So anybody with hemodynamic instability and signs of ongoing bleeding, then it should be ruled out. What is considered as what is considered hemodynamic instability? Do they have a threshold?
Less than 60 heart rate, less than 80.
The usual definition would be a systolic blood pressure of lower than 90, and a heart rate more than 130 beats per minute. So that's the definition for instability.
I thought instability is when you're not responding to the local.
Yes, that's also the third one, non-response to resuscitation. But the hemodynamic parameters is that less than 90, and then a heart rate of more than 130. Which patient would require emergent arteriogram? You have signs of ongoing bleeding, you have contrast extra, and then even with fluid resuscitation, there is no response. These are the ones that go into arteriogram. And the second subset is older patients older than 60, even without hemodynamic instability, even without extrav in the CT scan. There is a major pelvic fracture. It could be an open book. It could be a butterfly segment or vertical shear. What's the reason why? You have already reviewed the evidence. One of the the multivariate analysis is older than 55, older than 60. Why? Older patients have lost their ability to vasoconstrict as a compensation to minimize bleeding in the pelvis. So this is a subset. So remember, 60 and older, pelvic fracture, even without initial hemodynamic instability, even without the presence of contrast extra, but it's a major pelvic fracture, then this also would require arteriogram. And then the results, the bilateral internal iliac embolization, sexual function, it does not seem to be impaired. And then this is how we do it. So look at all the checklists, all of the branches. Look at the lateral sacral, look at the superior gluteal, obturator, internal pudendal, inferior gluteal, and the vesicle. So you have to look at all the branches bilaterally. So the common sites of arterial injury would include superior gluteal for SI joint disruption, internal pudendal from pubic rami injury, lateral sacral from sacral fracture as SI joint disruption, obturator and vesical artery from anterior pelvic injury, and inferior gluteal from inferior ligamentous injury. What is the diagnostic performance of contrast extra? You will see in this particular publication in 2003, sensitivity is 60 to 84%. We already explained the lower sensitivity. Specificity is higher, 85 to 95%. And then we already explained the age and need for embo. So regardless of the hemodynamic status, patient above 60, they require embolization even with a seemingly normal vital signs and hospital admission. There are a lot of articles proving that elderly patients should be a different subset. Pelvic arteriogram is sensitive in 85 to 97%, and then rebleeding occurrence is about 5% to 25%. So initial successful embolization, the chance of recurrence will be at 5 to 25%. Or initial angio was negative, the chance of another bleeding would be about 5 to 25%. There are also other independent risk factors for recurrent bleeding, transfusion requirements of more than 2 per hour before the arteriogram, finding more 2 injured blood vessel during the arteriogram, repeated hypotension after the initial arteriogram, absence of concomitant intra-abdominal injury, and a persistence of the base deficit. These are all independent risk factors for the presence of recurrent pelvic bleeding. So you have to watch for recurrence in this particular, if these parameters are present. So how do we do the pelvic trauma embolization? You have to go for the you have to use the Saturn's law. You have to go where the money is. So where the money is, of course, the internal artery branches that we have already outlined a while ago. So this the Saturn's law. So you have to go where the most common bleeding would be encountered, depending on the site or on the site of which bone is fractured. One study demonstrated that being more selective has more recurrence of bleeding, but compared to non-selective. Why? Because as a rule, our mind is wired to go selective. Because you want to minimize ischemic and necrotic complications. Why in this particular study, that recurrent bleeding also to be more common after selective embolization than after non-selective. Yeah, because the other branches that are spared, there could be reperfusion to the other branches. Because remember that the pelvic circulation, they help each other, collateral pathway. Gluteal necrosis, so we're afraid of gluteal necrosis, but according to these citations, at least 5 citations, they are usually not related to the embolization. They're usually related to the trauma, pressure necrosis from the trauma or from the binder. And how about sexual dysfunction? We already alluded to a while ago. They did a case control study, males undergoing bilateral internal iliac embolization. They found no difference comparing with a case matched pelvic fracture not undergoing embolization. So it's not a problem. It's not one of the complications. So how do we do the arteriogram? Begin with an aortogram at the bifurcation. Always perform selective internal iliac, even though they appear normal in the aortic injection. Don't stop at the normal pelvic run. Remember to evaluate also the extrapelvic sources, such as bleeding from the inferior epigastric artery. Use a temporary agent like gel foam or more selective one, coil. Your goal is to create ischemia, not necrosis. Avoid PVA, gel foam powder, spherical agents. Avoid alcohol, avoid glue, because they could cause necrosis. And due to the rich collateral pathway, embolization is always tolerated as long as the collateral pathway is patent. You start with an overview and then go selectively. In most cases, start with a pigtail, then progress to more selective. You can use your specific curve, the cobra catheter or other curves. And then selective is usually better. However, if the patient is actively bleeding, is unstable, you don't have the luxury of time, don't waste time trying to be super selective. Don't do a tour de force. It's much better to end up with a living patient rather than do an exquisite, super selective tour de force examination that would take time. So we'll look at cases. The case number 1, status post MVC, restrained driver. 2 passengers were dead on the scene. The blood pressure is 135 over 94, but the heart rate is 160. So, just to make the presentation quickly, so you would see the gluteal bleed, extra in the area of the left side. Look at the pelvis like the way you look at the clock. Make your checklist: rectus seat, pelvic sidewall, gluteal region, and the presacral region, and we see bleeding here in the gluteal region. Then you look at the abdomen, there is a lot of hemoperitoneum. So this is already more than 500 of hemiperitoneum. In addition to this, what do you notice? You notice that the IVC is already flattened. There's already a sign of hyperperfusion. And you look at hyperenhancement of the adrenal gland. And not only that, you will see hyperenhancement of the bowel wall, all pointing to you hyperperfusion. Remember, this was seemingly normal blood pressure. Don't be misled. The blood pressure is higher than 120 over 80. But look at the imaging. There is already evidence of hypovolemia, the flattening of the IVC wall, hyperenhancement of the adrenal gland because they're shifted into the adrenal gland for your flight response, and then also shifted into the shock bowel appearance, the enhancement of the bowel wall. And then this is the pelvic run. You would see there are a lot of bleeders in the pelvis. And in this one, there's already signs of hyperperfusion. You cannot do a tour de force. So you really have to go into the iliac right away and then do a showers of the iliac. So that's what we did selective in the iliac, shower it with gel foam, and then also on the other side, shower it with gel foam. And that's also the bleeder there, shower with gel foam. And then go back to the non-pelvic source. There was a pseudoaneurysm in the pancreatic bed, and this will need more time because you have to be more selective. And then we're able to go selectively into the pseudoaneurysm, and this was embolized. The patient was able to survive, and he was discharged home. And this is also the the SMA, and there was no bleeding coming from the SMA. The second case, also massive injury, ATV. So there's one season in the Shreveport region wherein there's a festival of ATV, and then we do see a lot of ATV. Yeah. They go to the slope, and then they fall, and then the ATV falls on them. So these are the ATV injury. He coded twice before transfer to LSU. On arrival to LSU, another code. He was taken to the OR where a pelvic packing procedure was done, and he was then taken to the IR for embo. So as you would expect, there are a lot of bleeding. You see in the internal iliac on the left side. You see also on the on the other side. This was embolized selectively initially with gel foam to control the bleeding, and then to have a better control, and then you were able to improve the hemodynamics with the shower gel foam, and you see that you already had the luxury of time to do coiling, and then you do a coil to secure the internal iliac. And then now this is the finished product. It's equivalent to bilateral internal iliac ligation. A third case, pelvic bleed, 48-year-old, involved in MVC. Initially, you would see the separation in here. So you would see the separation of pubic symphysis. You have lost your tamponade, and you will see bleeder here in the obturator artery, a large bleed in obturator artery. And then this was selectively catheterized, and then selectively embolized both with gel foam and coils. Then this is a post-op, massive bleeding after surgery. A call from orthopedic surgery. You would see the fixation device on the left side from obturator fracture. You would see that there's a large bleed coming from the superior gluteal. These are already after arrest in the operating room. Then we are able to secure selectively the bleeding from the superior gluteal with coils. This is another one. A motorcycle accident presenting with subarachnoid hemorrhage, bilateral PV fracture, and expanding pelvic hematoma. So this was mentioned, anterior bleed, but what was not mentioned, but look at this hyperdense material in the presacral region, so don't forget the presacral region. And then this is the global survey of the pelvis, pigtail. You would see initially there's no anterior source of the bleeding. Nothing in there. But since we were able to see a hyperdense fluid, hematoma in the presacral region, so we also did study the sacral branches. And true enough, we were able to see bleeders in the sacral region, which we were able to embolize.
Dr. Beck, can I interrupt with one question?
Yeah.
Can you tell us something about the corona mortis in relationship with the pelvic trauma? Is it something that we see on angio-CT of the pelvis? Is it something that we should see on the angiogram, on the pelvic angiogram?
It is
something that
great.
we should look for?
Describe the corona mortis.
Well, it's a connection between the anterior to the pubic bone, connection between through the obturator artery, the common femoral and the deep arteries.
It's not common, but if you see a pelvic bleed and then you do arteriogram and you didn't see initial bleeding in the pelvic branches, go to the lumbar, go to inferior gastrocantry. There's none. There's also study also the branches of the femoral artery below the level of the groin, because there could be reperfusion from there. So never forget that a less selective embo, if you don't have the luxury of time, is better than a technical tour de force, and the patient is dead. Next year is embolization done on one side, that the other iliac is also evaluated. Make sure there's no collateral flow. If iliac arteries are okay, but the patient is still hemodynamically unstable, check for lumbar bleeding or branches from the femoral. So this answers your question, or bleeding from branches of the femoral artery. when anticipating arteriogram, pelvic stabilizing device, you don't have to undo them. You can cut. You can cut through the pelvic binder to expose the femoral artery. You don't have to undo it. But if during the arteriogram you don't find initial bleeder, then call the trauma, referring trauma team. You can undo the pelvic binder temporarily because it might just be tamponading the bleeder, so you can see bleeding that was not initially demonstrated because of the presence of the pelvic bleeder, but ask permission from them. Mortality rate increases from 17 to 75% if the embolization is delayed beyond 3 hours. Let's look at the role of angioembolization by the other guideline. The previous guideline was based on the Eastern Association for the Study of Trauma, 2011, but this is a more recent one, very similar. So they advocate the use of arteriogram, they advocate the use of CT scan, they advocate those with hemodynamic instability and ongoing bleeding, the need for arteriogram, and they also put emphasis on the presence of contrast extrab. If it is present, they should go to arteriogram and embolization regardless of the hemodynamic status. And also, both guidelines also recognize that particular subset, elderly patients above 60 with pelvic fracture should be considered for pelvic arteriogram and embolization regardless of the hemodynamic status. When you look at the systematic review regarding efficacy of embo in pelvic trauma, 21 studies, you would see that the efficacy is 81 to 100%. The frequency for repeat arteriogram and control is 0 to 19%. And overall mortality, meaning mortality not entirely related to the pelvic trauma, 7 to 47%. Mortality related to pelvic bleeding, 6%. And the presence of complication is very low, only 1.1%. When the Eastern Association of the Study of Trauma did a survey, and what is the current management, 11 trauma centers, level 1 trauma centers, were able to see that in-hospital mortality is 9%, and most of the management that was used by these 11 trauma participating is arteriogram and external fixation. But one of the centers made use of REBOA. So what is REBOA? REBOA is resuscitative endovascular balloon occlusion of the aorta. If you've been watching the first season of the TV series, The Good Doctor, and one of the episodes featured REBOA and what's his name? That doctor. The doctor with ADHD.
Murphy?
No, it's not Murphy. I forgot, but one of the rounds, he was the one recommending a REBOA. So REBOA is resuscitative and the vascular balloon occlusion of the aorta. Only one of the centers participating. And what is REBOA? So you occlude the aorta at 3 zones. Zone 1, descending aorta from the origin of left subclavian of the celiac. Zone 2, paravisceral aorta between the celiac trunk and the lowest renal artery. And zone 3, infrarenal abdominal aorta from the lower abdominal aorta to the aortic bifurcation. So based on the injury, based on the CT scan, zone 1 and zone 3 are preferred, are the preferred site. Avoid occlusion in zone 2 because it will be causing visceral ischemia, and confirm occlusion on plain X-ray or fluoroscopy using the landmarks. So this is how they do it. This is an algorithm from the trauma center in Maryland, the shock trauma. Somebody is already hypotensive, not responding to partial or partial response to fluid and massive transfusion protocol. They access the femoral for future use of REBOA. And then look at the chest X-ray. If you see abnormality in chest X-ray that will give you an inkling that there might be some aortic injury, then of course you don't have to do. That's a contraindication to do a REBOA. If there is none, then you have to do a FAST scan. If the FAST scan is positive, yes. So you have to position the REBOA in zone 1, that is at the descending aorta, and then the patient is taken to the OR for damage control surgery for emergency lab. And then if the FASI scan is negative, and then look at the pelvic X-ray, is there evidence of mechanically unstable pelvic fracture? If there is, the patient is hypotensive, non-responding, then position the Reboa in zone 3 above the bifurcation, and then inflate the balloon, and then take the patient to IR for embolization. I think we have time to show the video. So this is the Reboa. The advantage of this now, it initially was large, and now it comes in set and friends.
Seen 60 Minutes to Live or something like
Hi,
that.
everyone.
Okay. So let's finish first. So I think we will have extra 5 minutes for questions. So the evaluation for safety, because this has been started in Japan, it was widely used in Japan before it was introduced in the U.S. But the problem at that time, I don't know. This is probably before the introduction of the 7 Friends, the smaller one. They had some problems. The survival rate was about 30%, but they have some complications in about 12.5%. They were able to limb loss in about 3 of the cases. They were the injury in the external iliac, and the other 2 with lower limb ischemia. All of the 3 complications resulted into amputation, but I don't know what size. But we look at the registry that is published by the Eastern Association for the Study of Trauma later on. So this is the Health Pack Review, the technology assessment that was published in 2016. Yeah, they said that although poor outcomes were initially, treatment with Reboa may be considered as a last resort for a patient with few options. This is the registry that was published in 2016 by the Eastern Association for the American Association for the Study of Trauma. They call it Aorta, aortic occlusion for resuscitation in trauma and acute care surgery, the use of Reboa. And let's look at their data. And from November 2013 to February 2015, they were able to accumulate 114. Two groups, a case control study, Reboa 46, open 68, and majority were males, about 81%, and majority mechanism of injuries, blunt injury in the abdomen and chest. And where they did it, aortic occlusion was done in the emergency room in majority of cases, 75% of cases, and the rest were done in the operating room, 25% of cases. When you look at the results, hemodynamic improvement with aortic occlusion, surgical cross-clamping, open, and Reboa, with comparative with the Reboa 62.3%, with open cross-clamping 62%. How about achievement of stability? Very similar also, 36 of the total population were able to increase the blood pressure to 90 millimeters mercury more than Reboa in 48%, and open aortic close clamping in 68 in 30%. So there was a significant difference between the two. The p-value was equal to 0.014. So it seems like in this initial data from the registry, you would see that Reboa is more effective at achieving hemodynamic stability compared to the more invasive cross-clamping of the aorta. As I have said a while ago, yeah, in trauma bay. So there's the issue right now, who should do it? Is it done by the vascular surgeon? Is it done by trauma surgeon? Is it done by the ED, or is it done by IR? But again, to resolve the issue, I think even though IR knows how to do it, it's just using a different material. It's the basic technique of IR, but they still require certification. So deployment was done in zone 1 in majority of cases. Zone 2, you don't do that, about 2.4%, unless it's just intermittent or short-term occlusion of zone 2. You do incur a lot of mesenteric ischemia. And then in 3, 19%. The second attempt was required with Reboa in 4%, with open cross-clamping more than 10%, which is 10%. Complications, which is quite different from the publication from Japan. So I presume that the one that they use here is the 7 friends. You would see that complication was uncommon. Pseudoaneurysm in 2%, embolism in 4.3%, limb ischemia, they didn't have any, as opposed to the 12.5% in the study that was published from Japan. And how about the time? Because you need time. You cannot really have the luxury of time. What is the time? The performance of Reboa compared to the performance of cross-clamping. You would see that they were very good in cross-clamping. Reboa is 6.6 minutes. Open cross-clamping is 7.2 minutes, with plus minus 5.6 for Reboa and plus minus 15 for open cross-clamping of the aorta. When you look at the results, overall survival is 21%, with no significant difference between the two groups. With Reboa, survival is 28%, with open cross-clamping 16%. There is a difference, but when you do statistical analysis, the p-value is equal to 0.12, so it's less than 0.05, which is therefore statistically insignificant. Conclusion, so it is a viable alternative to cross-clamping. So the data is still immature, and therefore we need more data. And I think this is 2016, and I'm sure as we speak now, there are more included in the registry, but they have not published the second part of the registry. But from publication of this in 2016, I presume that there are more cases with Reboa. So this is from the joint statement from the American College of Surgeons and American College of Emergency Physicians. They both advocate Reboa only as a last resort. Those who do hemodynamic instability without response to resuscitation. So I think we have enough time for this. The video is about 4 minutes. This is using the Mentis. The Mentis is a simulator for vascular interventions. Not only vascular interventions, cardiac interventions. I think they have the Mentis in Tulane. I don't know how much it costs, but maybe this is a good learning tool or a good training tool. Maybe we can collaborate with cardiology. Maybe we can petition to purchase one to be used by vascular surgery, by IR, and cardiology. So this is the simulator. You will see that using the simulator, the balloon, the BOA is now being placed initially. If somebody hemodynamically insignificant, and therefore to allow you to embolize, you need to control the bleeding. And the balloon has been inflated at zone 3 in the above the bifurcation. So the Reboa is inserted on the left side, and then the embolization is done on the other side, and you will see the wire now being crossed over into the area of the bleeding on the left pelvic bone. You see the initial guiding catheter with the cobra curve, and you will see the wire going into the internal iliac. And now, using the simulator, you will see that the wire is being manipulated selectively into the internal iliac on the left side. Using the simulator, you can also inject contrast, similar to you did in the actual vascular suite. You can collimate. And then the superior gluteal, where the bleeding was, is being cannulated now. DSA to verify location, so it's located in front of the bleeding. The microcatheter is positioned through the 5 French catheter and advance more selectively. So this is an option using gel foam. So using the simulator, you can choose what you want. And here, you can choose gelatin. And now blunt embolization proximal to the area of the bleeding. So you can simulate the actual vascular suite. So there are also EKG monitoring physiologic parameters. There's successful occlusion. And then option 2, using coils. So therefore you have to be more selective. Now the coil is now being deployed into the bleeder. Control DSA, there's occlusion and control of the bleeding. Now there's total cessation of the bleeding. So the question in here is that what should be the sequence of somebody with hemodynamic instability? Shall you go to OR first, go to IR, or go to IR first, or go to OR? So this is a case control study. You would see in here, OR angio, 49 in the group, angio, and then going to OR. When you look at the parameters, the length of stay and mortality is not different. There's no significant difference in mortality, whether you go OR first for damage control surgery and angio, or angio first for hemostasis and go to the operating room. There's no significant difference in the length of stay and mortality, but when you look at mortality related to the instability of the fracture, of course, angio going first before OR had shown to have more mortality compared to the OR angio group. This is the algorithm. This is the old algorithm in 2011. Before Reboa was utilized, you would see that the the one that used as an initial way to to triage your patients is of course hypotension, non-response to resuscitation. So if there's non-response, then you have to go to OR. And then if there's no hypotension, then you have the luxury of doing a CT scan. It is positive contrast X sub, and there's nothing requiring emergent surgery, go to IR. And then if there's if there's something that requires emergency surgery, of course, you go to OR first. Then if the CT scan is negative for contrast X rub, there's no injury requiring emergent surgery, then you have to have a low threshold for IR if there is SI joint disruption, pubic symphysis diastasis of more than 2.5, pubic rami fracture, butterfly pattern, significant hematoma more than 500, continuous transfusion requirement, age equal to above 60, even in the absence of contrast X rub, then you have to consider doing arteriogram. And this is the the World Society for Emergency Surgery. This is the most recent publication. You would see that they degraded it to minor, moderate, and severe, and then they base it on the Young Burgess classification of the pelvic fracture. And then you have to take into consideration other parameters, hemodynamic instability, mechanical instability. And based on this, they were able to come up with this algorithm. It is a minor lesion, non-operative management. If it is a moderate lesion, meaning classification 2 and classification 3, you need temporary mechanical stabilization. After you do that, go to CT scan. If there's a contrast blast, then you have to go to arteriogram. And then if there's none initially, and then there's ongoing instability, and you suspect other bleeding, remember 25% might need another arteriogram, then reconsider having an arteriogram. The new subset now is the severe lesion, stage 4, hemodynamically unstable, requiring massive transfusion protocol, unresponsive to resuscitation. Then you have to do damage control surgery. Then you have to consider Reboa. Then you have to consider embolization. So in summary, so we have seen the, the change in the algorithm with the introduction of Reboa. FAST scan does not have enough sensitivity to rule out, remember that. And then although X-ray pattern injury does not seem to predict hemorrhage, the use of CT scan and finding contrast X-rab is highly predictive of bleeding. Any question? If it is a zone 1, not more than 15 minutes. For zone 3, they still don't have because you don't want to induce ischemia in the visceral organs. In zone 1, you also compromise the flow into the intercostal. You could also compromise the flow into your Adam Kiewicz artery, anterior spinal artery, so you cannot afford that time. The recommendation is not more than 15 minutes. And the size recommendation, the average size for the aorta and descending area is about 20. So it's about 20. And then if you go down to the zone 3, they use usually 15. They inflate the balloon to 20 at the zone 1. they inflate the balloon to 15 at zone 3. Other question?